All right, let's talk a little bit about psychopharmacology. This is kind of fun. How many of you love drugs? Nobody, Casey, nobody answered that. Everybody loves drugs, right? You got a drug right there. That's caffeine. Oh, it's watered down. It's water now, but it was caffeine, right? So you had a drug. How many of you have ever taken Tylenol? You don't have to answer that. That's a personal, like, medical question you don't have to answer. I assume most of you have taken some medication in your lifetime, right? That's pretty standard. How many of you, yeah, I mean, you've taken any kind of substance, that's prescribed or not prescribed. You don't have to tell me about those. I mean, a lot of those are over the counter too, right? I mean, those are drugs. Any sort of exogenous chemical, right? A chemical from outside your body that you put in it, we could really call that a drug if it's going to have some effect on the way your body works, right? So those are drugs. So most people love drugs. That's a fair question, right? Everybody loves drugs. We've decided that. I almost wrote like I heart drugs, just...
Don't do that.
Don't do that? I don't care. I really don't. I'm just waiting until I get tenure, right? And then think of the things I'll say.
Then you can say lots of things.
I say lots of things anyway. We'll talk a little bit about pharmacology, psychopharmacology, drug action. Then we're going to talk a lot about neurotransmitters and neuromodulators. Who remembers last week we spent all of that time talking about ion channels and ligands and all of that fun stuff? We're going to revisit that, and I'm going to give you some cool information to go back in there, okay? But first, let's talk a little bit about drugs. First, what is a drug? As we just said, it's really any exogenous chemical, right? It's anything that is from outside your body that you put inside of it that's going to alter the function of certain cells. That's it. That's all it is. That's a drug right there. It's a pretty broad, generic definition. Now, for a drug to work, for our purposes, everything about, like psychotropic sort of drugs, right? Drugs that have some effect on your nervous system, you have to make some sort of endogenous chemical. Right? That is very similar to that exogenous substance that you're going to take. Otherwise, we're not going to have a receptor for it, right? Again, why does heroin work? Because you have receptors that are almost shaped like heroin for opioids that your body releases naturally inside, right? So you have some endogenous opioids that you'll release when you feel pain, okay? Those are great. They help reduce pain. Somebody thought, wow, that's really great. What we should do is make something that's even better than what you make, and then that's how you get things like OxyContin, right? And you get these sort of synthetic substances. What is a drug effect? This is a really complicated definition. It's the effect of the drug, right? It's whatever change that drug's going to produce. For our purposes, we're going to think physiological processes and behavior, right? So you're going to take cocaine. That's going to cause some change in physiological processes. That's going to cause some change in your behavior, okay? You're going to take Lexapro. That's going to cause some change in your physiological processes and some change in your behavior, right? So that's the drug effect. The site of action, that's simply where that drug molecule is going to interact with your cell, right? And that's where it's going to cause some change in the biochemical process that's going on inside your cell. It's going to open or close an ion channel. It's going to increase or decrease production of a neurotransmitter. It's going to have some effect on that biochemical process of that cell and group of cells, which in turn is going to affect your behavior. It's kind of straightforward, right? Not so bad so far. There are really 4 things you need to know when we're thinking about a drug and its movement through your body. The fancy word we use there is pharmacokinetics. You have to think about how it's absorbed. We'll talk a lot about absorption because there are different ways drugs can be absorbed. We're going to talk about distribution. That's going to be a short conversation, and I'm just going to say blood supply. We're going to talk about how it's metabolized. We're going to involve some enzymes, your liver, a few other things. And then we're going to talk about excretion. That's going to be also a shorter conversation. And I'm just going to say urine. That's where most of your drugs come out. But in between all of this, we're going to talk about lipid solubility again. All right, this is an important diagram. You all need to read each of these boxes. I don't know why the slides that they gave me are so fuzzy. It's just ridiculous. This image is in your book. It should be available to you, not a problem. Absorption, distribution, metabolism, excretion. We'll talk about the fun things there. What are the ways that you can take a drug? Well, there are so many. They each have advantages and disadvantages. We can think about those. They're going to be different for different kinds of drugs, right? Some drugs you have to take one particular way because the other ways are ineffective. Some drugs you can take in more than one way, right? How many, you don't have to answer this, and if I were you, I wouldn't answer it rapidly, but how many different ways can you take cocaine? There's like 3 or 4, right? You can inject it, you can inhale it, you can just rub it on your face. I don't think that's the way it normally works, but we'll talk about that in just a moment. All right, so some of the ways that we can actually administer drugs, IV, right, intravenous. Most folks have had an IV. That's a pretty standard. You know, you go to the hospital, the first thing they do is like give you a sack of saline, right? It's like, 'cause that'll cure anything. Just stick that in there. When all else fails, just put salt water in your body. All right. You ever think about it? People spend so long like learning just to like stick salt water in you. Like, I can figure that out. So IV, why is IV great? It's super fast. What's the point of getting a drug into your body? The absorption. We need to get it to that distribution system. The distribution system is, again, your vascular system. If we're doing this IV, we're right in there. We've bypassed any sort of slow absorption. We've bypassed any sort of breakdown period, right? We're just right in there. Now, the bad thing about that is it's super fast, right? If you're allergic to a drug, there's not really any time to correct it. Uh-oh. How do we get this out of his blood supply? Well, can you pull the plug on him and just let all the blood out? Doesn't really work that way, right? So once you've got something in an IV and it's into your blood supply, we're sorry. If you're allergic to it, that's kind of the end of the story, right? We also have intraperitoneal. That's an IP injection. That's going to be into your gut, right? We're not really sticking it into a specific place. This is going to be primarily for lab animals. Okay? Don't really do this with people a lot. Sometimes I think doctors want to when like they're like little kids who don't want to take their vaccines, right? Just like run around with a big needle and like jab them in the stomach.
That's how they do like the fertility injections and then.
Yeah, there are some applications for humans where you know, mostly it's going to be lab animals though. I'm not really happy about getting stabbed in the stomach. That just doesn't seem like something fun. But there you go, right? You can sign up for that if you want. We also have intramuscular injections. How many of you have had a flu shot? You don't have to answer that because that's a medical question. They'll give you the flu shot quite often in the shoulder, right? Like in the deltoid. That's going to be an intramuscular injection. How many of you have ever had an IM injection that burned? Yeah, it happens sometimes, right? The reason for that is the pH of the substance they're injecting in you is different than the pH inside your body, and it makes it burn just a little bit. So you got that. I had the rabies vaccine in my shoulder. Yeah. It was a fun one. 3 times I had to get it. It was like a 3-step process. Then they had to take my blood out to make sure I had enough of the rabies antibody. So there you go. I was doing some work. I was going to do some work with ferrets. Ferrets are really. I don't have rabies. I don't think. So the thing about the rabies vaccine is I might actually have rabies. Like sometimes when they give you the injection, you'll develop rabies, right? This does happen. So I have to tell my wife periodically, like, just in case later I go crazy, remember I had a rabies vaccine, because it really seriously could happen. There's like a slim chance, but there you go. So if I start having some weird behavior, you'll know what's going on. Subcutaneous is just going to be under the skin. Not a big deal. Sometimes you'll just take things orally like Tylenol, right? Just pop a couple pills, take a liquid, whatever. The downside of oral administration is hydrochloric acid. How many of you have hydrochloric acid? Yeah, all of you do, right? Because it's in your stomach. Great job, Riley. You're on top of this. So hydrochloric acid will break down a lot of things, right? That's why they don't let you use it as like a facial cream, right? That'd be a good skin peel, I guess. Right? Get a little stomach acid up. Somebody could dry heave a little. No. I'm thinking about like where you're going to get hydrochloric acid, right? You're just like making your own, so why pay for it? I mean, you might want to filter it first. I know there are people who rub like horse placenta all over their bodies too, right? You guys are making some weird faces. You can look that up on the internet.
Don't moms eat their placenta?
Moms are weird just in general.
So yeah. Right?
I don't know, but they make things out of placenta, right? That you can get as like beauty products. I'm not making this up.
I know that you can, I've heard of being eaten a lot.
Yeah.
That's what I hear about.
Just like fry it up with
Like
some
all those
onions.
vitamins or whatever.
Yeah, I wouldn't recommend it.
I'd rather not.
Hasn't one of the Kardashians done that?
I don't know.
Yeah.
They still baffle me. They're like the ninth wonder of the world. Because, I don't know. There's this, I don't know, you guys Norm Macdonald fans? Who's a Norm Macdonald fan? Yeah, who doesn't love Norm Macdonald, right? So he's got this new bit. It was on Netflix, I guess. It was called Hitler's Dog. I don't know if you saw that one or not. Which was kind of funny, and then he actually did amazingly talk about Hitler's dog at the end, which was not terribly important. I would put a disclaimer on this, not for the kids, right? So if you're like watching it at preschool or something, probably not appropriate, right? But he has this whole bit about how he's upset the Kardashians are famous and not like the guys who've landed on the moon. So he goes into this bit like, you know, like there are only like 12 guys who've landed on the moon, so we should like know all 12 of them, but he's not quite sure what the Kardashians have done, but everybody knows them. So it's kind of this, actually it was a really interesting social commentary, I thought. And it was funny because it was Norm Macdonald. So you should watch that. Also, if you're into history, like I said, he talks about Hitler's dog. You learned something there. Nobody was interested in that. But stomach acid's going to break it down. Some things, again, aren't going to survive that, so you're going to have to take it in a different way. Sometimes there's another reason. Maybe it will survive stomach acid, but if you're vomiting, right? So sometimes you will take anti-nausea medication through a different opening, right, as a suppository there, infrarectal administration. So if you can't keep something down, maybe you can keep it up. I don't know, right? I'm trying to think of the other direction there. So sometimes you'll have to take things intrarectally. Again, the nice thing about that is it's a mucous membrane. Same thing as sublingual, right? Sublingual is not oral administration, so we want to kind of say there's a difference there because that's going to be absorbing through a mucous membrane under your tongue, right? It's going to be the same thing intrarectal. Also, inhalation is not the same as snorting. Okay? Inhalation actually has to get in your lungs, right? So you actually have to get it into your lungs for it to be considered inhalation. How many of you have ever snorted something like Flonase, right? No, that's a relatively common thing, right? So you are supposed to snort Flonase, by the way. That's the correct administration there. That's not, you're not inhaling Flonase because it's never getting into your pulmonary system, right? It's going into your nasal cavity, and through that mucous membrane, it's being absorbed into your blood supply, right? So snorting and inhalation are two different things, okay? Just want to toss that out there. Topical administration. This is when you categorize what you're doing. No, it was topical. This is when you put something on top of your skin. How many of you have ever used Icy Hot? Right, something like that. Icy Hot, that's a topical administration, right? It's just the cream you're going to rub on. And we'll go that way. Transdermal is a little different than topical administration. We didn't really talk about transdermal. Things that are typically absorbed transdermal, that's going to be like nicotine patches, hormone patches, things like that. That's kind of transdermal. How many of you get seasick? And there are patches for people who are seasick, right? So kind of same idea. There are two other routes of administration I doubt any of you have experienced, because these are pretty hefty. That's intracerebral or intracerebroventricular. This is when we squirt stuff directly in your brain, right? Whatever you've got going on is so serious, we're not going to trust it to go anywhere else. Jaquia, right in the brain, right there. This would be if you had some sort of brain infection, you've got some inflammation, if you've got something serious going on, and we really need to get that solved, right? We're not going to waste time sending that to the rest of your body and taking a chain straight in the brain. Okay? Questions about routes of administration? Hey, for those of you that didn't know there were multiple ways to take cocaine, here you go. So if you do intravenous, you can inhale that. You can take that, oral administration, or you can snort it, right? Intranasal. Those are 4 different ways that you could potentially do this. These are adjusted for concentration, so they're relatively the same dose depending on the route, right? You would measure this differently. But this shows you just the concentration of cocaine in the blood over time. Obviously, you can see that an IV has a quick spike, right? You're putting it directly in the blood. Okay. If you think about oral administration, look where the peak is on that. That's much later, right? Because you've got to go into your stomach. You've got to absorb it through your stomach, right? So that takes some time. So it's just highlighting the different sort of routes of administration here for different drugs. This can explain also how many of you, when you think about cocaine, how many of you think about taking cocaine orally? Nobody does, right? Why would you do that? Well, you wouldn't. It's like an hour later. Who wants to take cocaine and wait an hour for your high? It just seems like that takes a lot of planning, right? I mean, it's like, oh man, you know what? I think I'm going to get an urge to get high in about an hour. I'm going to go ahead and take one of those cocaine pills now. See what happens. The problem with that is, and we'll learn later, that doesn't really work for like learning and memory. If every drug you took, you didn't get an effect until an hour later, most drugs wouldn't be as addictive, right? Because it's like you take the pill and you're like, well, I didn't do anything for me, and you're going to be out doing something else, and then an hour later you're digging that canal, remember? And you're like, whoa, this canal digging is so great, and that's what becomes addictive. It's like canal digging. So there you go, right? That's why folks want to take it as an IV, or they want to snort it, right? Because you can get that high, and even you get that high pretty quickly, right? That IV, it's right in there. You get that big rush pretty quickly, so you have that nice tight association. Now, don't worry about this. Hey, so, well, I mean, that's just distribution. Not a big deal. How do we get drugs into your brain? Again, it's going to be through your blood supply. There is, however, the blood-brain barrier that we have to worry about, remember? So a couple things need to happen. Drugs need to be lipid soluble, typically, right? They need to be able to pass through those capillaries, okay, so they get into your brain. Alcohol is extremely lipid soluble. That's why alcohol gets in, does its business, okay? Lexapro, very lipid soluble. That's why it works, right? That's why it has an effect on your brain function and your behavior, because it can get into your brain and it can do things. Okay? If it's not lipid soluble, take it all day long. It's never going to do anything because you got that blood-brain barrier right there looking out for you. All right. Now what do we have to do next? Well, you've got a drug in your body. How many of you have ever taken a drug? That's a really personal question here. Nobody's even going to answer that. Like you can answer it and say like Advil, right? Because we've established ibuprofen is a drug, and you're still not comfortable admitting to that. Why is that, Casey? I take drugs every day. I had some caffeine earlier today. That's a drug. I mean, you know. I'm trying to think if I took any drugs yesterday. I don't think I did. Take some osteobiflex. I don't know if that counts. I think it does. So, what do we need to do? Well, we need to deactivate this drug. You got a bunch of enzymes in your liver that are just going to chop that drug up into little pieces that are no longer going to be active. So if we want to continue this alcohol story, there's alcohol dehydrogenase. Basically, it cuts a hydrogen off of your alcohol. Guess what? It's not alcohol then, and it doesn't have any effect. That's awesome. Okay? Anytime that you want to deactivate a drug, you need to chop it up into something that's not the drug. And those pieces need to be less lipid soluble. They need to be less lipid soluble so your kidneys can grab onto them. Guess what your kidneys are made of? They're made of lipids, same as basically everything else, right? They're cells, they have a lipid bilayer. If you're putting something in there that's lipid soluble, it's just going to slip right back out. And some drugs are like that. Some drugs that you take, when you metabolize them, they actually become more effective because that initial first metabolite is actually more lipid soluble and it more readily gets into your brain. Sometimes we call that prodrug. Sometimes we will intentionally give you a drug that we know needs to go through one round of metabolism before it's effective because we know maybe it won't survive your stomach acid. Maybe there are other reasons we need to let it develop into the drug and then deactivate it. So there's going to be an extra step. Okay? I'll write that word down, prodrug. So that's awesome, right? So why do you take drugs? Well, you take drugs to get some effect, right? I mean, even if it's Tylenol, why did you take Tylenol? Because you have a headache, right? You took Tylenol because you stepped in a hole and twisted your ankle, right? Why are you taking why are you taking an SSRI? Okay, maybe you're depressed, maybe you're irritable, right? Why are you taking Strattera? Because maybe you can't pay attention in class, right? There are reasons you take a drug. Okay, so you want to have that effect. How do we know how much drug to give you? Just like, got a 20-sided die, we're just going to roll it, and whatever number comes up, that's how many pills you take. No, we have to think about things like dose-response curves, okay? We have to think about how much drug are we giving you, what effect are we getting, right? How many of you have ever taken a drug and then you had to take more of a drug? Because that initial bout didn't work, right? Advil, great example, right? I think about this sometimes. I look at that bottle of Advil and it says, like, take 2 pills if you're 12. It's like I think about how much bigger am I than a 12-year-old? I've got to be like twice the size of a 12-year-old, right? Like your average 12-year-old, right? It's probably like half my size. I think about my nephew's 10. I think he'll be 11 in September. I mean, he just now hit like 80 pounds, you know? And I'm thinking, like, if he would take 2, and like how many times 80 am I, right? Like how much bigger is my liver? Do you know what I mean? I'm like trying to do the math on this, and I'm thinking I could take like 4. That's probably not going to hurt me, right? It's not a great idea. It's not a bad idea. Dose response curve. We got to think about that. How much drug we can give somebody to get the effect. We also want to calculate something called a therapeutic index. This is great. So not only are you taking a drug so that you'll have some effect, you're also taking a drug so you don't die, right? And we don't want to give you a drug that's going to kill you. Now, most drugs, not only do they have what we call a therapeutic effect, they also have a side effect or side effects, right? Morphine is a great example of this, and we'll talk about morphine a bit later. Morphine is phenomenal at pain relief. It is also phenomenal at making you stop breathing, okay? So, what we want to do is we want to figure out how much morphine do we need to give this guy. I mean, he was in a really bad car accident, right? His leg's broken. We've got to do some operations. We want to give him enough morphine so he's not in pain, but not so much morphine that he stops breathing, right? Because that seems to be, like, I'm going to spend all this time trying to fix this guy's leg. The last thing you want him to do is just stop breathing, right? So you got to find somewhere in between. Now that's your therapeutic index. How far apart is your effective dose and your lethal dose, right? For something like morphine, that's a fairly narrow range, right? Okay, I just talked about like Advil, like, well, I'm just going to double my dose randomly because I think I can. Well, that's fine with Advil, right? I could probably take like a handful of Advil and not really cause any immediate effects. Long term, I got to worry about some liver toxicity issues, right? But immediately, I take a handful of Advil, like whatever, right? If I take like a handful of morphine, sounds like a bad idea, right? So you don't want to start like increasing the dose. I think about this sometimes when I think about LSD. LSD is probably one of the safest drugs you'll ever take in terms of the therapeutic index. You can take, so like let's think about the standard dose you've got to take for LSD. You can take a dose 20,000 times higher and it still not kill you. Let's imagine you're taking cocaine. Can you take a dose of cocaine 20,000 times higher than the dose you need to get high and it not? No. If you take that much cocaine, you'll just instantly explode. I saw it on YouTube. They were going to prosecute the guy, but there was nothing left. So they just let it go. The same thing works with, let's think about Lexapro, right? We've been talking about that's a fairly common drug, right? I think a lot of, if you're not on it, you know someone who is, right? I mean, I think that's pretty standard, right? Is that still a standard SSRI they give people? You see clients, you know.
Not that much.
Not that much.
Not enough to
But you've seen clients with Lexapro, right? I mean, that's a...
Not yet.
Not yet. Lamictal?
My brain's thinking.
Jeez, Casey.
Sorry.
You're worthless to me. It's okay. What are some other commercials you see? Prozac. Everybody knows Prozac, right? Huh? Zoloft. Yeah, let's say you're taking some Zoloft. That's awesome. So you take a little bit of Zoloft, right? I don't know how much, but you're taking enough. You just want to randomly go in there and go like, I'm going to crank this up 20,000 times. I'm going to feel really good. No, that's a bad idea. That will kill you. Okay? It's not going to kill you with LSD, right? That's a strange example that has a massive therapeutic index there. But other drugs, they have narrower therapeutic indexes. You have to worry about those side effects. Hey, who loves affinity? Well, everybody does, because that's what affinity is. It's how much two things love each other, right? So if you think about like spaghetti and meatballs, man, there's a lot of affinity there, right? If you think about like pizza and beer, there's a lot of affinity there, right? If you think about like students and studying, there's less affinity there, right? Affinity in our case, we're going to think about two molecules, how readily are they going to jump together, right? When we're thinking about the effectiveness of a drug, we want to think about what is its affinity for that receptor. The higher its affinity, the more powerfully it's going to be attracted to that, the more powerfully it will bind, and the longer it will stay bound, and the more active it will be. Let's continue our story here about morphine, right? Okay. So you have endogenous opioids. You stub your toe, you're going to release some of those. Okay? They're going to bind to your opioid receptors with some level of affinity, right? That's how this works. Do you know what has higher affinity for those receptors than your endogenous opioids? Is morphine, right? So morphine has a higher affinity. Do you know something that has a higher affinity than morphine? What's an opioid that's even more powerful than morphine? Right? And so in this case, I'd like you to think about OxyContin, for example. That was actually specifically engineered by someone in a laboratory to have a higher affinity for your opioid receptors. Right? That's what they wanted. They set out to create something that was more powerful. Right? And so that's why, in my mind, I think you've got to worry about those synthetic drugs. When in doubt, go natural. That doesn't mean like go to the Healthy Life Market and go, oh geez, I broke my leg. I'm going to rub me a little, I don't know, ginseng on it or something, whatever you buy. That doesn't work, okay? But when we're thinking about synthetic drugs were designed by someone intentionally to be more powerful, right? That's why they have more powerful effects. That's why OxyContin is a more powerful opioid, than some other more natural opioids would be. Does that make sense? Okay. Hey, guess who's got graphs now? I do. Here's your dose response curve. We give you some dose, you have some response. We give you more dose, you have more response. It's that simple. Now there is a plateau. There's going to be a plateau where you are not going to be able to get a higher response out of that, right? So caffeine is an example. Joanne, you're going to take some caffeine. You don't have to answer this, but what's like the highest dose of caffeine you think you've ever taken at once? Let's make up a number. 200 milligrams. That's that's a moderate dose, right? I wouldn't say that's like an outrageous dose. Some things have much higher concentrations of caffeine. And if you look at that beverage you had, it probably says it has like 90 milligrams per bottle, right? I know this off the top of my head. 91. Okay, so it has 91 milligrams. If you were to drink a cup of coffee, like from Starbucks, you're probably getting in that 200 to 300 milligram range, right? Maybe even 400 to 500 milligrams. Some of those are quite high. If you take like pre-workout supplements, right? So sometimes you'll see those pre-workouts, they have caffeine in them. That'll be in the 200 milligram range, sometimes just a little higher. But there's a cap, right? There's like a cap on how much like the response you will get, right? So caffeine has a plateau. So let's say, you know, we're at 200 milligrams. Let's say we're at 300 milligrams. Let's say we go up to give you, you know, what if we give you like 600 milligrams? You're not going to get any more effect out of that than you would at like 300 milligrams, right? So there's going to be a limit.
Is that because the receptors that you have are limited, so once they're taken up, the rest of them can go?
Bingo, right? So you've got that limited amount of receptors. The drug itself has a limited effect on the receptors, right? So they're going to be able to have their effect for a limited amount of time. It's going to go through that breakdown process. All of these things are working, so you're going to saturate that at a certain point, right? Now, caffeine will have a plateau here. Another drug that sort of does some of the same things as caffeine is amphetamine, right? You have some similar effects. They're much more powerful. You also have a plateau with amphetamine. It's just going to be up here, right? So if your caffeine dose response curve looks like that, your amphetamine dose response curve might look like that, but you're still going to have a plateau because you're going to run into the same biochemical limits. Absolutely. Okay? So what you want to do is you want to think, because you're cost conscious here, right? You want to think like, am I taking too much of that? Like what? Like keep dialing yourself back till you get that maximum effect. That works, right? Actually, I would start down here and work my way up, because then you've got to worry about tolerance issues, right? And if you start way out here, then you're like, tolerance is going to happen. You have to take more. That's a separate story we'll talk about in a minute. Questions about that? That was a great question. All right, here you go. Here's a dose response curve for morphine. This is showing you your analgesic effect, so your pain relieving effect. This is showing your depressive effect on respiration. That distance in between is the margin of safety. Okay? We have to give you, you know, how much of the drug do we have to give you before you stop breathing versus how much do we have to give you to relieve your pain. If we give you drug back here, that's not going to do anything for you, right? We can give you, I remember when I took some early classes, we had a guy who was, he was the chair of the pharmacology department where I went to graduate school, and he said, I will put any substance in my body if you let me select the concentration, the rate of administration, and the route of administration. He didn't put any substance in his body. He didn't care what it was. And his point was, you have to take so much of a drug to have an effect. If you take less than that, then you're not going to have an effect, right? Your deactivation process will be faster than the influx of the drug. You're not going to have an effect, right? Let's say to have any effect at all with morphine, you've got to take 50 milligrams. Well, what if you only took 5 milligrams? Well, what's going to happen to you? Nothing, right? You're not even going to know that's there. Your body's going to break that down. It's going to take care of it. Not a problem. But we do have to worry about that lethal dose, so we want to stay somewhere in between here. And notice there's some overlap. That's what you want to worry about. So if your effective dose and your lethal dose were like this, and let's say you want to get something up here like 50%, I mean, look, that's also got some considerable likelihood it's going to cause you to stop breathing, right? So that's what you have to worry about, is where these curves are close and where they overlap. If you're doing Advil, like so here's your effective dose of Advil, here's your lethal dose of Advil, right? So think about that wider margin of safety there. This does not mean go out and like take bottles of Advil, right? Again, you have to worry about long-term liver toxicity. I've actually even, I saw this report recently that in athletes, you know, a lot of folks will take Advil to reduce inflammation, right? I've actually heard in athletes that it increases inflammation. So it was kind of an interesting report. So there you go. tolerance, the basic idea with tolerance is over time you've got to take more of a drug to have the same effect. One of the reasons for this is going back to your idea with the receptors. Over time you're going to downregulate those receptors. There's this idea of homeostasis, right? So you want to stay at a certain level. If you take cocaine, that's going to jack your level up pretty high, right? And so what your body's going to do is try to bring you back down to normal. There are a couple ways you can do that. One, again, is you're going to downregulate receptors. The other thing you can do is you can upregulate enzymes. Okay? We call it enzyme induction, right? So if your liver starts to create more enzymes, right, to break that down, alcohol works this way, right? We talked about alcohol dehydrogenase. If you are a regular drinker, you're going to start making more alcohol dehydrogenase. So when you ingest, 1 can of beer, you've got more of your enzyme to break that down. So instead of 1 can, you need 2 cans. Instead of 2 cans, later you're going to need 4, right? And it keeps building, okay? There are obvious problems with this because who remembers that margin of safety? Every time you start to build up tolerance and every time you have to increase your dose to get the effect, you get closer and closer to that lethal dose, okay? Also, you have to worry about withdrawal issues, right? Because you've downregulated receptors, you've upregulated enzymes because you want to stay at that homeostasis level. Once you remove that drug, you're still at a deficit. You're at a major deficit on receptors, right? Because they've been used to operating with that extra boost. So if you think about dopamine receptors in cocaine, if you've been taking cocaine for a long time, you can get rid of some dopamine receptors. Then all of a sudden you stop taking dopamine. Okay. That's fine. Or cocaine, but you don't have any dopamine receptors, right? You're going to feel awful. This is why you relapse, right? Because you're going to feel horrible. And when it comes to alcohol, in fact, withdrawal can actually be fatal if you don't do it properly. If you're an alcoholic and you've been drinking for a long time, if you stop drinking suddenly, you can get delirium tremens, DTs, and you can die. And the reason for that is you're used to that alcohol having that depressive effect, right? We'll later talk about GABA agonists, right? So it's going to have this negative effect on your nervous system. So you've been trying to jack up the level of your nervous system while you're taking that alcohol to pull you down, right? The whole time in the back, you've just been increasing and increasing and increasing, and you're taking more and more alcohol to bring you down. As soon as you remove that alcohol, right, you're going to snap back to that sort of augmented level, and you can cause some serious problems. Your seizures, again, it can be fatal. This is why sometimes they will tell you, like if you go in for rehab and you've been drinking, if you're going in for alcohol, they won't take you in right then and tell you to stop drinking. They might tell you to go home and, have a pack or two, because they don't want you to stop suddenly, especially if they don't have a place for you, right? They don't want to send you home and say, hey, you need to stop drinking right now, because that could send you home and kill you. Now, it's not me advocating for you to continue to be an alcoholic either. I want to be clear about that. But you need to have a medical professional help you with these things. Does that sound reasonable, Casey? Is that what I'm supposed to tell them? Sure. Sounds good to you. Great. Hey, who loves placebo effects? Placebos are awesome, right? You've all experienced the placebo effect. How many of your moms have kissed your knee when you scraped it and it felt better? Does your mom still do that? You kind of laugh like it's probably like your sister or something, right? No, I don't know if you have a sister. You do? Do you want another one? Oh. I got an extra one. I was trying to get rid of. She's not that helpful. I got one sister that's she's good, so I'm gonna hang on to that one. But I got this other one that's like so. I got a brother too, but the nice thing about my brother is he's younger than I am and he's bigger. So he's really great for carrying heavy things, just do what I tell him. So that's helpful. So I'm probably not going to get rid of him either. But the other sister, she's kind of small, so she's not terribly helpful about carrying big things. She's not that reliable either. My other sister's kind of reliable. So nobody saved me a Christmas gift. No. She's pregnant, so you'll get a niece as well in the deal. Does that sweeten the pot? All right. There you go. I tried. Placebo effects. How do placebo effects work? Well, it's an inactive substance. We're going to tell you it might work. You might think it works. And guess what? It might actually work. It's just kind of weird. And there are brain regions that are involved in placebo effects, which is kind of cool. This is one of the reasons antidepressants are so hard to get to market, right? So Casey, this will just really ruin your life. When you're wanting to develop an antidepressant, right? How many of you, so this is like serious moment, because we're going to have that. How many of you know someone who is depressed? You don't have to answer that, right? But if you do, where do we send those people, Casey? 4th floor, we've got the clinic, right? This is when you advertise for the clinic.
Like, I don't know what you want to say.
I want you to say the clinic upstairs. The clinic.
Upstairs.
So we have a place upstairs. What's that cost a student to go up there?
It's free.
Wow. You guys should just go there. Because, like, so very rarely, I mean, what's it cost to go to it? I mean, you're going to pay like $125 an hour
Really expensive.
to go to somebody. I'm offering you for free $125. You just got to walk up to the 4th floor once a week. Every week, it's going to be $125 in your pocket. Right? You should take advantage of that. Never again will you get free mental health care of the quality that we're going to offer you upstairs on the 4th floor in the clinic, right? That's true, right? You don't work in the clinic, do you?
Yeah.
Oh.
I'm there right now. Don't ask me.
Yeah, don't ask for Casey because she knows you, but somebody else can help you up there. If you need to go, if one of your friends need to go, please take advantage of that, right? So, they see people up there for a variety of reasons. Anxiety issues, depression, you have difficulty transitioning, if you've got some life things going on, whatever it is, take advantage of it. Again, it cost you, well, I guess it is costly. It cost you walking up 4 flights of stairs. We even fixed that. We gave you an elevator. So you don't even have to walk upstairs. You just ride the elevator. We're really cutting down the cost big time, right? So stop by if you guys or your friends need some help. We also, should you tell them about Tom?
Oh, the Tom Talks. Okay. Yeah, so, yeah, he's the new, like, if you live in the dorms and you just want to talk to somebody, we have one of our clinical students now lives in the dorms and is the, like, dorm counselor.
Counselor in residence.
I don't know what it's actually called.
No, it's actually called counselor in residence.
All I know that I remember is his Tom Talks joke. He's going to, like, have these talks where he talks to students who might need help or might just want to, get some information about mental health. He's going to call them Tom Talks, like Tim Talks. And he laughed really, like, his Tom way about it. Like, ha ha ha.
Okay, so that was a little corny, but, I mean, it wasn't you. You're just reporting what he said.
Oh, yeah, no, I don't know.
But if you need that, he's in one of the towers, right? East?
Yeah.
Towers East. So he's in Towers East. So there's another free resource for you if you need him. Why did I mention all of that? Really, because that's important information for you. I think some of you might need, or you might know somebody who needs to go there. We've got pamphlets and flyers you can pick up.
I'll also note too for Tom, he's going to have like available times to where people can just stop by.
Yeah.
So, and like the clinic where you go upstairs, you have to kind of coordinate with someone to do like an intake interview and then start setting up times to be seen. For him, if you just have a problem, you can just stop in and talk to him.
And if you are waiting on somebody, it only takes like an hour. You just try to keep them in there because we're like the desk assistants, we like sign in and out people.
Yeah.
And you try to keep the appointments within 1 hour, and you just pull this cute little card that we made you. And it says 1, 2, 3, and that's like the waiting line. It's really nice.
Wow, there you go. Take advantage of that. It's a free $125 an hour service, which you'll never get again. It's just good for your pockets. So, why did I mention depression? And that brought us into that great conversation, which was important info that you needed. Lots of folks experience depression, right? It's a fairly common thing. I don't want to make light of it if you're having trouble, but I also want to say it's like not a big deal. We have resources for you. Things are out there. If you need help, you can get the help, right? So it's not anything. When I say no big deal, I mean there's like no stigma attached, right? It's like not a big deal. Lots of people are depressed. Let's get you the help you need and let's move on, right? Have a great day. The problem though is, they'll often give you medications like SSRIs or something to treat depression, but those can be difficult to get to market, right? So somebody will develop an SSRI or an antidepressant. Well, that's awesome. Maybe it's not an SSRI, something. And they'll give it to a rat. And they'll go like, well, that rat seemed happy. So that's cool, right? So we got to try things in rats first, right? Because they're rats. And then we'll get to where we're trying it in humans. And when we try this in humans, we'll have, so in research, how many of you took research methods courses? Somebody had to. Yeah, right? So you always have to have a control group, right? And so you might actually have multiple control groups in these cases. You'll have somebody who's on the drug, a group of people. You'll have somebody who's on the placebo. It's going to look like the drug, but it's really just going to be just whatever. You'll have somebody who might be in a different category who doesn't get any treatment. And then you might have somebody in another group who just goes down and they sit and chat with somebody, right? What's interesting is that quite often the drugs don't make it to market because they're not considerably better than the placebo, right? And this is particularly true with depression. It works for other things as well. So sometimes, and again, I wouldn't recommend like trying this on your own, just like thinking you're going to get better. Get some professional help. But sometimes just being told you're going to get better is good enough, or good enough because there aren't any side effects. That's the thing we have to worry about with actual drugs that we give you, right, Cindy, is the side effects. We can give you an SSRI, but hey, guess what? It's going to make you sleepy. It's also going to like disrupt your sexual function. So if nothing else is depressing you, that will, right? I mean, that's like, so you're feeling bad. Let's make those parts not work anymore. You know, that's definitely going to, everybody gets cheered up then, right? And those are the common side effects of antidepressants, or sleep disruptions and sexual dysfunction. The sleep dysfunction probably is not going to make you, it could. You feel like all I do is sleep all day. But maybe you need to get some rest. So, depression, we got to worry about side effects with drugs. Placebo seems to work fairly well. Sitting down and talking to somebody seems to work fairly well, right? So we're not going to give you a drug. We're not going to put a drug on the market if the effect is not powerful enough to offset the side effects and to beat out those other methods that are either on the market or just those placebos or sitting with someone. Often, Casey, this is just for you. They'll do the one of the control groups will be the Kindly Professor group. Are you familiar with Kindly Professor? So rather than like having you talk to a professional, they'll just send you to a nice guy in a cardigan, and he'll talk to you for a little bit, and quite often that makes you feel better. And if you don't believe me, ask Mr. Rogers.
Very Milker Mister.
It is. It's, yeah, yeah. I don't think it's as I think it's an older approach. I don't think they do it as much. So there you go. Placebo effect. That's just going to be kind of interesting thing to keep in mind. Now we're going to talk about some fun stuff, because I don't think any of that was fun, right? Maybe this is more fun. We're going to talk about agonists and antagonists. Okay? An agonist, very simply, is going to increase the effect of a neurotransmitter. It's that simple. Somehow. There are literally like 15 different ways this can happen. We'll talk about those. But the end result, and here's kind of the fancy phrase, facilitate postsynaptic effects, right? It's going to enhance neurotransmitter function. That's it. Okay? You can do this in a variety of ways. We'll talk about those ways. Cameron, don't worry about them right now. Just know that it increases neurotransmitter function. An antagonist, on the other hand, is going to do the opposite. It's going to decrease neurotransmitter function. Pretty straightforward, right? It's going to block or it's going to inhibit that postsynaptic effect. So it's going to decrease neurotransmitter function. Agonists and antagonists are going to typically be neurotransmitter specific. So we're going to talk about dopamine agonists or dopaminergic agonists. We're going to talk about cholinergic for acetylcholine, cholinergic antagonists. Okay? We might talk about broader categories, right? Something that would affect a catecholamine or a monoamine, right? Which is going to be a broader group of neurotransmitters. But we'll worry about that when we get there. But typically, they're going to be neurotransmitter specific. Okay. Now, where are the places that we could enhance or inhibit neurotransmitter function? Okay. One of those is going to be at the production step, right? If you want to release dopamine, guess what you need to do? You need to make dopamine, right? If you don't have any dopamine, guess what you can't do? You can't release it, okay? So, if we want to think about a, there are drugs, so there's a precursor called L-Dopa. It's a pretty common treatment for Parkinson's disease. Those folks are losing their dopaminergic neurons, so we're just going to help the neurons that are still there make more dopamine by giving them that precursor. Okay? So that's going to be an agonist, right? So it's going to increase neurotransmitter function. There are things we can do to block. There are all kinds of synthesis steps, right? Tyrosine hydroxylase, for example. That's an important step that takes L-Dopa and makes it into dopamine. If you were to block the effect of tyrosine hydroxylase, guess what happens? You make less dopamine. So that's going to be an antagonist, right? It's pretty simple. What if we can have an effect on storage or release, right? What happens if we block those vesicles? Okay. If we block the vesicles, guess what? We're not releasing neurotransmitter, right? So that's going to be an antagonist. What if we make those vesicles more easily released? Well, that's going to be an agonist. We're going to increase neurotransmitter effects, right? Things can happen at the terminal as well, right? Hey, here's a fun one. Who loves botulism? Nobody raised their hand on that. Did we talk about botulism in this class? We didn't talk about Botox at all. That's something. So Botox, some people like Botox, and you can always tell those people because their faces are like this, right? That's how you know. Somebody likes Botox. You can really see inside their cheekbones, right? Because there's facial. So I watch this, as I always do, I watch insurance commercials. And I saw one recently with Dennis Quaid. I don't know if you guys know Dennis Quaid. You'll know him when you see him. He was in, what was that great movie he was in? Dragonheart, with Sean Connery as a dragon. I'm sure you all saw that one in 1994. When did that movie come out? Was it 1994? Just throwing that out there. I thought it was awesome when I was a kid because it was like a big dragon. But I was also 11 probably when it came out. I don't know if watching it now I would find it as interesting. What was that other movie he was in that was good? The Rookie. If anybody saw that one. Yeah, nobody saw that one. What else is he?
He was in The Parent Trap with Lindsay Lohan when she was young.
Day After Tomorrow.
Was he in it?
Day After Tomorrow. That's a movie. Nobody saw that one? Somebody did. I didn't. I don't know. Dennis Quaid. There you go. He looks like 10 years younger now in this commercial, and I can tell because you can see in his cheekbones. Used to he had a normal face, and now he's got these extra cheekbones. So and his face has got kind of like the Jack Nicholson Joker face, right? Yeah, it's really tight, and so I think he had some Botox. You can tell. So there you go. So that's what Botox will do. It'll actually prevent the release of acetylcholine. So it can cause paralysis. So when your mom used to tell you don't make that face or it'll get stuck like that, had she actually had some Botox, she would have been accurate. I don't know. They also use it now for migraines and sweaty armpits. Now you're thinking, right? I got some headaches and some sweaty armpits. I'll give it a try. At the same time, I'll just tighten up my face, look a little younger. I don't know. Anyway, that's Botox. It's going to prevent the release of the neurotransmitter. Alcohol will actually increase the release of GABA, right? So there's a that's going to be a GABA agonist. We're going to be releasing more. Botulism toxin is an antagonist, right? Because we're going to decrease release. This I know is fuzzy. Okay, it's in your book. It's a good diagram. Again, it shows you really there are like 11 different places where we can think about agonists or antagonists, right? And really we're going to think about it either making a drug or making that neurotransmitter, breaking down that neurotransmitter, storing it or not storing it, releasing it or not releasing it. If we want to think about, that's all presynaptic, before we've released the drug really. Postsynaptic, we want to think about, can we block a receptor? If we block it, guess what happens? That's an agonist, right? Because we're not going to be able to have an effect. What if we mimic the drug? What if I give you a drug, or the neurotransmitter? What if I give you a drug that mimics dopamine? Well, that's going to be an agonist, because it'll get in there and bind, and it'll act just like dopamine. We can also work on enzymatic breakdown. We can prevent that. We can accelerate that. We can block reuptake. This is how SSRIs work. We're blocking the reuptake of those neurotransmitters, right? So it's going to increase the effect. We should talk about, did we talk about autoreceptors? I can't remember. Autoreceptors are interesting. If you release neurotransmitter, there's going to be a receptor on that cell that's releasing to measure how much of the neurotransmitter comes out, right? So if we're measuring how much dopamine's coming out, how do we know when to stop? Well, when we've been, when dopamine is attached to that autoreceptor. If I've released so much that my autoreceptors are stimulated, then I know I can stop releasing dopamine. On the other hand, if we were to block an autoreceptor, we just continue to release dopamine, right? So blocking an autoreceptor is going to be an agonist. Activating an autoreceptor is going to be an antagonist, because we're going to think, oh, I've already released a bunch of dopamine, so I'm going to stop. We talked about receptor blockers. A direct agonist is going to be something that works right on that ion channel, right? It's going to work right on that receptor. It's going to open it. Non-competitive binding is kind of interesting. There's competitive binding and non-competitive binding. When we think about competitive binding, the agonist or antagonist, whatever it is competing with the neurotransmitter for the same binding site. They're both going for the same location. Who gets there first is who wins, right? Non-competitive binding is when the drug is going to bind somewhere else. We don't care if the neurotransmitter binds or not. That drug is going to bind somewhere else completely different, and it's going to do its business one way or the other. That's non-competitive binding. Okay? Hey, this is awesome, right? Here's your direct agonist, direct antagonist. They're binding right onto that binding site. Not a big deal. It's going to be competitive, right? Competitive binding. Non-competitive binding, you've got your neurotransmitter. Who really cares what it's doing? Because we've got the drug binding somewhere else where the neurotransmitter cannot bind, and that drug is going to override the neurotransmitter, right? So it's going to override it either as an agonist or an antagonist. We talked about reuptake, destruction of neurotransmitters. Not a big deal. We should talk about some specific neurotransmitters, right? We'll talk about the ones that are important, briefly touch on things they may or may not do, where they're located, and then we'll revisit these as we need to. There is this guy, glutamate. This is an excitatory neurotransmitter. If it's an excitatory neurotransmitter, guess what? It has to open cation channels. If we're talking about cation channels, those are sodium or the super awesome calcium 2+, right? Okay. We will talk about NMDA receptors and AMPA receptors later when we talk about learning and memory. How many of you have heard of ketamine? You don't have to tell me where you've heard of ketamine, right? Maybe you have a cat that you had to take to the vet and they gave it ketamine as an anesthetic, which is what they do. They'll typically use ketamine. How many of you have a horse? Yeah. they'll use ketamine as a horse an. The reason they do that is you don't have to like intubate, right? So you can just like shoot it with some ketamine. Horse goes down, you reach in its whatever and do its thing and pull out whatever's in there, retwist its stomach or whatever. For some reason, horses manage to like rotate their stomachs a lot inside their bodies. They can like twist up their intestines and stuff, which I don't know how horses do that. I never see them like jumping in the air and doing barrel rolls, but that seems to be a problem with horses. So they'll use ketamine as a veterinary anesthetic. Some people will use it recreationally. It's a dissociative anesthetic, right? It has some hallucinogenic properties, kind of in the same group as your serotonergics. No, it's not a serotonergic with LSD and so forth. Other folks will use it as a date rape drug, right? So you can drop it in someone's drug or in drink. It's not, because it's not a like you're down and unconscious anesthetic, you'll still be up walking around. You're just not really in control of what's going on, right? And so people can still lead you out to their house and like do things to you. So that's why you should always like put a lid on your drink. Right? You should always just take like one of those like cat food lids when you go out and just like snap it on the top of your. You guys don't do this, but that's like a serious thing you should do because you got to watch this stuff. There are weirdos out there, and then there are like weirdos out there who try to do things. Those like a different group of people, but. The first group, you just ignore them. The second group, you got to watch out for them. So ketamine, they'll also use it in the battlefield sometimes, right? So this is actually a decent anesthetic for someone who's just been injured in a military interaction, right? Because again, assuming that they don't have injured legs, they're going to be able to help you carry them out, right? So they'll be able to still walk. But because it also screws around with your NMDA receptors, they're not going to really remember what happened to them. So the likelihood that they develop PTSD is reduced. So that's interesting. They also use ketamine for depression. I know, right? And that's pretty crazy. They'll prescribe ketamine to folks who have intractable depression, and it seems to help. Interestingly, Casey, this is just for you, it seems to not work on your NMDA receptors. It works on your opioid receptors when you're dealing with the relief of depression, which is kind of interesting. But ketamine will screw around with NMDA receptors and you won't remember things. This is why individuals who testify after they have been given ketamine, in a date rape sort of situation, they don't really have all the details because they can't remember. It's biologically interfering with their memory process because NMDA is required. NMDA receptors are required for that process. So if you learn nothing else today, make sure you get one of those cat food lids. They look like this. Sometimes I have a little tab on it. There's like a picture of a cat on it. Just put that on your drink lid. If you get really fancy, you can like glue some jewels on it or something, so you know it's yours. Or just always take your drinks to the bathroom with you.
I feel like if you bring a cat lid in general, people will just stay away from it.
Then it works either way. I am always full of great advice. I don't know why you guys... See, I gave you great advice on, date safety. That actually was good advice. The cat lid thing was a little stupid, but seriously, you should monitor your drinks when you're out and be careful, right? Great advice about how to rip off people with the airbag pills, right? So the airbag for your brain, we got that. Double up your Advil dose if you're bigger than a 12-year-old. So learn all kinds of things. Hey, what about GABA? This is gamma-aminobutyric acid, for those of you who really want to know. It's the inhibitory neurotransmitter. It's actually made from glutamate with this guy, glutamic acid decarboxylase, which is this other enzyme. And that probably got one of you excited out there in the audience. The rest of you don't care. What's GABA good for? It's good for like shutting things down. Because it's inhibitory, then it's got to open anion channels. Not an ion channel, but anion channels. So what anion do we have? Chloride, right? So we've got our chloride channels going with chloride channels. What are some things you can take? What about benzodiazepines? How many, you don't have to answer this. How many of you have been on or know someone who's been on a benzodiazepine? You know how you can tell, Casey, if somebody's been on or is on a benzodiazepine? See how most people are oriented this way? People on benzodiazepines are oriented this way. And they're on the lowest surface possible because they're asleep. Okay, that's how benzodiazepines work. You should be on a benzodiazepine for about 6 minutes. That's about as long as you should take these, right? You shouldn't take a benzodiazepine for an extended period of time. They're immediate. Somebody is having sort of a, I'm going to call it, it's not the right term, a catastrophic meltdown, right? They're having a situation where we need you to get to sleep now because your arms are still flailing, right? So they'll give you a benzodiazepine to drop you down, and that's really it, okay? After that, that's done. Okay, so you ever see kids that have been on benzodiazepines for years? Yeah, it happens.
Sounds awful.
It is. It's horrible. But it's going to open up a bunch of chloride channels. It's going to cause a lot of inhibition in your nervous system. That's what's going to calm you down. So it does have this anti-anxiety effect, right? Does that make sense? But it's problematic if you're taking benzodiazepines for a long time. Here's some other neurotransmitters: acetylcholine. Out in the peripheral nervous system, it's going to be for muscle contractions. It's also going to play a role in learning, memory, sleep. We'll talk about that when we get to those chapters, so don't worry about it. Dopamine, man. Who loves dopamine? Everybody. That's the point, because it's involved in reinforcement and reward. Also, it's involved in like movements and learning and attention. Dopamine does a lot of things. It's probably one of your primary neurotransmitters. You've got epinephrine, norepinephrine. This guy has some bigger effects out in the PNS with your autonomic nervous system, but also for vigilance. Serotonin's great for mood regulation. This is why we give people who are irritable selective serotonin reuptake inhibitors, right? We're going to increase the amount of serotonin that they have. Histamine is important for wakefulness. We'll talk about that with sleep and the sleep chapter. If you don't believe me, go home and take an antihistamine. See what happens to you. Take some Benadryl, you'll go to sleep. I mean, most of you will. Some of you won't. Some people take Benadryl and it'll actually ramp you up a little bit, right?
Wait, sorry. That's real?
Yeah.
We hadn't seen my...
Yeah.
I thought it was just because she was Canadian. But last year... that was a joke. In case anybody didn't catch that. We always talked about how like she would take Benadryl at night and like she had to stop taking it because it would like make her super like anxious or like oh wow, we always made fun of her. We were just like,
No, it's real.
Canadian.
It happens. It happens. All the time. Happens all the time when I take it, at least.
None of us believed her.
No, it does. It's not a lot of folks, but it happens, believe me. Yeah. So there you go. Opioids. I don't know if you guys have ever heard of opioids. You hear much about that these days? You don't. You don't see it a lot in the news. You know. So can I say something though? Like I wish like half the people who were reporting on opioids would stop and then just start doing something about it instead. Because I think we know it's a problem. You don't have to tell me anymore, right? Just do something else. I mean, like we got this. I mean, we know it's something. It's on our radar. Like let's shift our efforts to doing it, and just stop telling me how big of a problem. I know how big of a problem it is. One more sob story is not going to make me come up with a better idea to solve it. But maybe you could if you stop telling me those stories. That's my take on that. I think we still need the stories so people don't forget it. We still need as many, just enough to keep us going. Just a little boost once in a while, right, Casey? Put our efforts somewhere else. We've got limited efforts. It's finite resources.
I worry about how people like get used to hearing about it instead of
Yeah. It's like, oh yeah, everybody's on opioids, man. Just keep moving, right? And it does. It seriously becomes an accepted thing, right? It's like not even like you hear these stories about how many overdoses were there over the weekend, and you're like, okay. You know, I mean, really, right? I mean, how many of you have seen someone overdose on an opioid? I mean, like a lot of folks, it's a common thing, right? And you head over to CVS and somebody's just in their car, and you're like, well, it's really tough, right? There you go. That's my story on that. Hey, what about endocannabinoids? Let's talk about that for a while. I noticed the cannabis was around the other day. I'm not going to ask who went to the cannabis. And you have to say it cannabis because it was a bus. It's not cannabis, as you would say the substance. You know, it's the cannabis. It was parked over by that abandoned church, right across from Sheets. I was over there at Sheets, like putting some air in my tire, and I looked over and I was like, "What is that broke down bus?" And then I like read the name. I was like, "Oh, that's."
Yeah.
Really? Well, that's interesting.
Nice.
I'm not saying he's not nice. I didn't go visit him.
I mean, I don't know.
I was in a hurry. I had to go somewhere,
I
but
just wanted the dogs.
yeah, I didn't see that he had dogs. I guess he was inside the bus at the time. He just had like the marijuana flags out. I don't know how many of those he sold. I'm assuming some people in here bought a marijuana flag. That's just going to be my assumption. Just in general, I'm just like, there's like a number of you in here. I'm going to say somebody, at least you thought about it, and then you looked in your wallet and you're like, I got like $3. So I guess not today. Interestingly, well, not so interestingly, it's involved in appetite regulation. I don't think that should be a real shocker to anybody, right? So this is also a real thing. People getting the munchies, right, when they use marijuana. One of the reasons they give people marijuana is so you get the munchies, right? If you have a disease that causes you to lose a lot of weight, right? If you have something that's causing you to lose your appetite, let's imagine you are under some heavy cancer treatments, right? And what's a great way to increase your appetite? Well, marijuana is a great way to do that. So there you go. Just grows right out of the ground, too. Except for here. Here we decided to make you have to pay the extra for somebody to grind it up in an oil so you can use it that way. Because people in West Virginia have so much extra money to spend that they've got all that extra money to spend on those drugs when they could just like grow it at home and get what they need. Whatever. I wasn't in on that one. They didn't ask me. Hey, here's that NMDA receptor. Remember that time I told you about it? It's also got this like magnesium thing in there. We'll talk about that later. It works for glutamate. Here's a GABA receptor. Here's your GABA. Benzodiazepines can get on here. Barbiturates, that's cool. Alcohol can get there too. Opens up a chloride channel, not a big deal. All right, acetylcholine, we said it's related to sleep. That's stuff for GABA. Don't worry about it. Here's acetylcholine in a rat brain. Lots of stuff goes everywhere. That's important. Here's the synthesis process, acetyl-CoA and choline. You put it together and you make acetylcholine, and then coenzyme A is a byproduct. Here's acetylcholine esterase. You're going to break that down to choline and acetate ion. Not a big deal. Here's some things that are interesting. Who loves black widows? We already talked about botulism. Black widows will actually cause the release of acetylcholine, so it'll actually give you a convulsion. Whereas botulism will do the opposite. You can also get some curare. That's a good poison if you ever wanted to, you know, if you want to poison somebody but you don't want them to choke like Joffrey Baratheon. That was nice. Spoiler alert: that kid dies.
I was impressed and I was like, she did spoil it.
But I saw that, so yeah, I saw that episode actually. I got 2 minutes. I saw that episode before I started watching it. It's like I knew this kid died. And then Natalie Dormer, I felt so sorry for her. I was like, this is the second time I've watched one of these episodes where she's married some crazy dude who was a king. Because I saw her in The Tudors. I don't know if you watched The Tudors. She married Henry VIII, right? Typecast. Dopamine's everywhere. We talked about this guy. Don't worry about that. Catecholamines, Parkinson's disease. We'll talk about it as we need to. Don't worry about that. We should probably talk about that. We'll pick up here on whatever that next day is, 443, because I want to talk about monoamine oxidase inhibitors a little bit.